Hello everyone, let me know if you can hear this. Perfect. How's it going, Caitlin? We'll start in just a few moments here. Doing pretty good actually. It's another Friday, but days really don't mean much during COVID, so it's just a good day all around. Does anyone recall which slide we left off on? I think it was the dosing regimens. Maybe you guys remember. All right, perfect. And C-Mace, I can't remember what was your first name again? I got the photo directory now, so I'm trying to like correlate everyone. Slide 74. Okay, yeah. Isabel. Kayla, okay. Oh, no, that's okay. I just wanted to double check. I see the same group of people usually talking to me here, but I wanted to correlate it back with the photo directory. Since I can't see in person, I'm trying to like learn people by at least by how they chat with me in the videos. It's like I'd seen my advisees in my Zoom sessions, and like that's it. Didn't really see anyone else, but at least I have a photo directory, so it's good. And at least place emails with names nowadays. I think one of your quiz and I think your homework assignment is due today, and then we'll talk about the prescription assignment. I believe for the 31st. But I can double check. Is it pronounced Kayla or is it Kalia? How do I pronounce that? Kaylee, okay. That's what I thought. The A is silent. That works for me. I always had the benefit of having a very easy to pronounce name, although I did have one time in elementary school on a Valentine's Day card, someone spelled my name A-D-U-M, which I thought was pretty funny. Sometimes I am A-dumb, so... Oh yeah, it stuck with me all these years, for sure. That's okay, no one's dumb, we're just momentarily silly, I guess. Well, thank you, Marley, for that. Alright, so let me go ahead and start recording here. And thank you for joining me. Hopefully we'll have a few more that will hop in here. I want to finish up the pediatric section here, and then we'll get into the next one, which will be our, I think we're talking about drug dosing, TDM kind of stuff. I'm just going to pull that up just so I have it in the chamber here. Hey, Nicole. Okay. So anyway, getting into this, and of course, if you have questions, please post them up on the sticky board or in the chat. I'm much more likely to get to the questions in the chat sooner because I'm looking at that directly. So yeah, so continuing on. So we discussed about the different pharmacokinetics parameters of pediatric patients and how they differ from adults and how they kind of develop through age as they're aging up. And so kind of getting down into the practical application here, talking about different ways that we can dose these patients in terms of like different strategies. And so the first one here is age-based dosing, which is just like it sounds. You're going to be dosing based off of how old the patient is. So if they're 2 to 5 for codeine, they're going to get this much. If they're 6 to 12, they'll get this much. The downsides of this, actually the plus side, and really the only upside, is it's pretty easy to remember in practice. So if you deal with this age range of children all the time, you'll get pretty familiar with those dosings and kind of know it like the back of your hand. Unfortunately, though, it kind of assumes that the pharmacokinetics are equal in each of these age ranges. So a 2 to a 5-year-old is going to react exactly the same throughout that whole spectrum. And we know that's not really the case, especially as they are, the younger they are, typically you're going to see that it's not really going to hold true in a lot of instances. But not only that, you could have a particularly heavy or particularly thin patient within this range, and you can see how they may be under or overdosed as the case may be, just depending on the situation. I recall not too long ago I had a patient who I believe was 19 years old, and the weight was something like 20 kilos, and you're just like, well, that can't make any sense at all. They're only 44 pounds. And so, but that they had a chronic condition. They had they had a I think very severe cerebral palsy or something like that, to where they just did not have a lot of muscle mass or weight on them, and so we had to dose it, according to that. So you have to be very careful here. So Rashani was asking, would you take their weight into account when dosing? Well, that's exactly what we're going to get into. Thank you for the transition there. So body weight dosing is going to be much more common, though, and you're going to see this is generally going to be the way you're going to do this for majority of your peds patients. And so, for instance, here you can see like neonates and infants, they're going to get between 20 to 30 mg per kilo per day divided Q12 or something like that. And so you can see here how it'll change. And normally, you may see this when you're looking up your drug information assignment. If it's applicable, you'll see a section just for neonates typically, and then peds patients, which may be broken down into further age groups, and then adults. And all of that's taking into account those differences in kinetics between the groups there. And typically, again, the rule of thumb is when they start to butt up against the max adult dosing, that's where you're going to stop. You don't want to necessarily continue weight-based dosing beyond that. Beyond those max adult doses, because you're going to end up kind of overdoing it. We have cases where you'd have 16-year-old linebackers coming in from an accident on the football field, and they weigh 100 kilos, right? And so I'm not going to dose them beyond what an adult would get. At that point, they're functionally just an adult, right? So that's one thing you always want to consider there. Most common scheme we're going to be using here, and again, you may find that there can be some issues of altered kinetics here, depending on specific patient factors, but for the most part, this is going to work for like 95% of your patients, generally speaking. So some disadvantages for body weight. Again, you can see there's potential over or underdosing, especially in overweight children, especially as they get particularly obese. They're going to have a much higher percentage of adipose tissue, to where we may need to sort of adjust for this. And I'm not necessarily going to get into the weeds on that, but just know there are some ways we can adjust for obese patients and making sure that we're not going to over or underdo it depending on the drug that we're talking about. And we know this is a problem. We know there's a huge obesity epidemic here in the U.S., and certainly something you'll contend with quite often. Oftentimes, I'll see a child whose weight looks like it was incorrect, almost looks like they had put in the patient's weight as pounds under kilos, and I have to double check, and the nurse will be like, no, the patient was actually that many kilos. And so it's always good to double check. If something doesn't look right, make sure to call, make sure that was done correctly there. One way you can get even more exact than body weight dosing would be body surface area. And so this is not only going to take into account the patient's weight, but also takes into account their height. And so the benefit of that is it helps to mitigate extremes in weight in terms of what kind of drug dosing you're going to get. So an example here is corticotropin, 150 milligrams per meter square. Whenever you see meter square, that's referring back to body surface area. And you're going to find that this is also frequently used in oncology. So if you ever work in peds oncology, you'll see this done all the time. So very precise in terms of calculating the exact dose for a patient, and again, it helps to limit that chance for overdose, especially like an obese patient. So if they're particularly short and obese, that's going to take that into account, as opposed to someone who's much taller who might be a normal weight, even though the weights between those two patients are roughly the same. Problem though is that one, there's several different BSA calculations out there, so just make sure if you're using this, you're going to use whatever the standard is for the organization you're working for. And then it can be difficult to estimate length. So if you imagine a young infant, it can be tough to kind of lay them out on the ruler and making sure that they're stretched out so you get the actual accurate length. Height can be tough, so do the kids have shoes on or not? Getting a 2-year-old to stand still for more than a nanosecond can be exceedingly difficult, so this can be tough, but you try to do your best in order to get the most accurate height possible. So I want to look at a few different, let's see, Shelby says it's really hard to get height on, I'm assuming child patients or CP patients, because they're, yeah, absolutely. So yeah, cerebral palsy, when they have those contractures, yeah, that can be really difficult, I imagine. Yeah, so that's a really good point too. So again, given a given disease state, that can be pretty difficult. So looking at different administration routes and some of the challenges you're going to see with that, looking at IV administration, the site can be really important here. You will see that especially with peripheral veins, they can be quite difficult to establish a line in. They can be very easy to blow if you're not careful, meaning you can actually the vein will basically blow open and you can have fluid running into the surrounding tissue. And so you want to be careful with that. Sometimes we want to make sure kids will have a central access, meaning that we will place perhaps like a central line that will allow for a catheter to kind of be snaked over to the inferior vena cava and administer drugs there, as opposed to a peripheral line, depending on the type of drug that we're giving. The volume of drug can be really important too, especially like a neonate. If you're giving, we'll talk about fluid in just a little bit, but looking at the volume of drug, it's very easy, especially neonates, to potentially even dilute a patient's blood out and actually have an effect on their hemoglobin and hematocrit, more so the hematocrit, based on giving too much volume of drug. So typically we try to make sure the things are concentrated as much as possible in order to try to limit the volume we're giving for certain patients. Especially if you have multiple drugs and they have different frequencies going in, it can be really tough, especially if you only have one line accessible. You may need to find that if it was really difficult to get that first line in the first place, you may have to run drugs sequentially. You can't run certain drugs together due to physical incompatibilities. It can just be really complicated, as it turns out. And then looking at some of the mechanical and technical issues in terms of, one, again, actually getting that line in the first place. Frequently in pediatric institutions, they'll have what they call an IV team, which are going to be a set of nurses who are especially trained, and they have a lot of experience in getting really tough lines, and that can actually help out there. I don't know if anyone's ever seen there's a device called WeSight, but I know there's other ones where they actually use infrared light. You can shine that on the skin and you can actually see the underlying veins and stuff, and sometimes that can be helpful to try to access a line there. And then we'll talk more about therapeutic drug monitoring coming up in the next section, but this is where we're basically doing blood sampling to measure levels of drugs in the blood. And that can be tough too, because especially if you have a patient who's getting several different blood draws being done, especially in a neonate, that can certainly have an effect on the hemoglobin hematocrit, such that we try to pool all those things together. So if we can just do one draw and get multiple tests run off of that, or as many tests as possible, we try to do that to help limit the amount of blood we're having to take from the patient. See, Nicole said I had a toddler who had her central line blow, and her mom kept calling her the Michelin baby. Oh, that's so sad. No, poor baby. Probably all filled up full of fluids. It's no good. So this is an example of one way we can try to mitigate giving too much fluid to a patient, either whether it's just straight like IV fluids or if it's particular medications. Typically, you're going to see that this is where the line would be. This could be an IV bag. It could be a mixing chamber, depending on how that's done. But then basically it's going to run through some sort of pump device. And the pumps are designed to administer the drug at a very steady rate that is selected by you, the provider. Namely, you set how fast things are going to run, and then the nurse should be the one actually programming this in most often. And so here's an example of a syringe pump that we would use. This is the one we use at Nemours, and you can see here how the syringe will fit here in this chamber. This can actually detect the diameter of the syringe, so it knows what size it is, and then this will then push that in over whatever set rate that you set it at. And so the nice thing with this is it has drug libraries in it, to where if they're running in the drug, say Rocephin, or if it's dopamine or whatever the drug may be, you can run it in at very specific rates. The concentrations are set. It helps to limit the number of medical errors that can be made here, because it's very easy if you were just running this, having to do the math yourself and figure all this out, to make mistakes. And giving too much, too little can mean life or death in many instances for some of these medications here. So, but more often than not, they're going to be using oral administration, certainly the most common. And the dosage forms really matter here, since many children will not be able to take solid dosage forms like tablets. You have to use a lot of liquid medications, and so that can be challenging, especially when they don't want to take it. They can frequently make you end up, basically you're going to end up wearing it. In a lot of cases, they spit it back out at you. And so getting the appropriate dose can be challenging, because we talked about teaspoons and tablespoons and all of that, but depending on where you get your spoon from, they can have very different volumes that they'll actually measure out there. And so this is why things like medicine cups can be useful, because they at least have some demarcations in terms of the volumes there, but even those have some inadequacies. I've done some measuring myself and have found they've actually been pretty inaccurate. Obviously, I had nothing else to do with my time. But frequently dosing syringes are going to be much more available nowadays, and they're going to be the most accurate ways you can do this. So it'll be a syringe, has the volumes on it. That's going to be the most accurate, right? You also want to think about the sensory appeal of dosage form. So the flavor can really make a difference. And that's why if you go to like Walgreens or Publix, you'll see they have like little flavoring stations to make things basically taste like whatever you want. I remember when we were first setting up the Nemours pharmacy, we had originally bought cherry flavored Tylenol, because that was kind of like the cheapest thing that there was. And so we said, okay, that sounds like a good idea. And we almost had a revolt from the nurses, because they said, we are not going to carry cherry flavored Tylenol, because we are going to be wearing most of that, because that stuff's gross. And so we said, okay. So then we end up having to buy the slightly more expensive grape flavored Tylenol, and all was right in the world. And yeah, it turned out cherry flavor stuff is generally pretty gross. So this is a big thing to consider there. Just want to think about drug-food interactions. Kids might drink a lot of milk, which makes sense because they're developing their bones, but that can bind up with a lot of things. You have to consider inactive ingredients. A lot of kids will have allergies to dyes and whatnot, so you have to consider, do you have dye-free solutions of medications and things like that are available to you. So this can be challenging depending on the patient. So whenever you're prescribing meds for this group of kids, remember to obtain the most up-to-date weight as you possibly can. And this can be tough, especially if it's been a while since the last time the kid was measured, the last time the kid was weighed. I've had parents who would bring their kids in, to the ER, and they are actively in cardiac arrest. And, say it's a 10-month-old, right? Very small changes in dose can mean a big difference. And we asked the parents how much the kid weighed, and they gave us a number. And then when we actually had measured or actually weighed the patient themselves when we had the chance, it was actually they had grown since then, right? And so that discrepancy can mean, a big difference when you're talking about doses of epinephrine and many other medications. And so try to get the most current weight you can. Make sure you're checking with available references. So make sure you look this stuff up, especially if you don't deal with kids often. This can be a very anxiety-prone sort of thing. So like if you ever want to see the most anxious people in the world, like bring a pediatric code into an adult ER, and everyone's going to lose their minds, because it's a little kid and the doses are smaller and they're just not used to it. But make sure you double check your references, right? And then if you're talking to them, if it's not, say, a life or death situation, I always go to the extremes because that's my environment that I come from. But when you're talking with kids, like make sure you're being specific to the age of the patient, and you're speaking their language essentially. So for instance, like my 4-year-old's starting to pick up on the idea of medicine, and not to play with medicine, and medicine make you feel better, and things like that. Versus if you're dealing with like a 2-year-old, you're probably not going to get very far, And then if you're talking with older children, adolescents, make them feel like they're somewhat in control. Talk to them, like they're people too. Their parents might not be better off. The medical literacy may not be there. So, consider your audience and what's going to be most appropriate for them. So now I want to get into some drug dosing calculations. This stuff should be relatively easy compared to some of the more difficult calculations we did previously. So I want to go ahead and talk about some of the steps we're going to do, and this will feed into when we talk about our prescription assignment, which I will address towards the end here. So anyway, so looking at this, we're going to see that, let's say we have a patient who is 15 kilograms and they're requiring amoxicillin for acute otitis media. And they're getting 90 mg per kilo divided BID, and they're getting amoxicillin suspension 400 milligrams per 5 mLs. How much should this patient receive per dose, right? And we don't really care necessarily about the milligram amount. We want to actually know what to write on our script. We want to know what to tell the parent to give, and so this needs to be in mLs, right? So how would I go about doing this? Well, first off, you want to note here that we have these 3 pieces of information. We know how big the kid is, how much they're getting, and then what we have available to us. And so the first question is, well, how much should the kid get per dose, right? And so what you see here is, you notice it's 90 mg per kilo per day divided BID. So this is the important bit here, is that you're going to have to divide this by 2, or this number here by 2, okay? Because it's divided. If this said per dose, if this said 45 mg per kilo per dose BID, that's different. I wouldn't have to divide at that point, right? But this whole divided BID, that's the important bit. So anyway, so I know they're going to be getting 15 kilograms times 90 mg per kilo per day is a total, there's a total daily dose of 1350 here. And then in order to get their per dose amount, you just take that 1350, it's divided BID, and it's 675. So pretty straightforward so far, right? So then we can go ahead and say, okay, well, we know how much they should get in milligrams. Well, what do we have in terms of our drug here? And again, most drugs or many suspensions are going to be listed as per 5 mLs, and that's due to the old school sort of teaspoon sort of dosing methods here. So what I always like to do is make sure you divide that out and just go ahead and get the per ml amount. So just do the 400 divided by 5, and I know that I'm going to have an 80 milligram per ml concentration. And then at this point, it's fairly straightforward. You just take that 675 milligrams per dose divided by the 80 milligrams per ml. The milligrams will cancel out, and so then I'm left with 8.4 mLs per dose. And that's what you would write on your script. You'd say amoxicillin 400 milligrams per 5 ml suspension, 8.4 mLs BID, POBID, right? And again, I'll go over those details on the scripts a little bit later. So that's pretty straightforward. And again, if you're not used to doing it, it can be a challenge, but I at least want to get you some practice with that. So this is actually a really bad example here because actually ranitidine was just taken off the market the past month or two. So there's some concerns for carcinogens and things like that. But regardless, let's go ahead and stick with this example. Let's say we have an 18 kilo patient who requires Zantac. This is Zantac is a brand name. It's a H2 blocker used for decreasing stomach acid production. We use it for GERD type symptoms. And they're going to get 4 milligrams per kilo per day divided BID. Our ranitidine comes as a syrup. It's 15 milligrams per ml. How much should they receive per dose? Well, let's go ahead and figure all of that out. Okay, so how are we going to actually calculate this out? What are the steps that we're going to take to do this? I should probably make sure that my calculator's not blocked by my giant head. But what we're going to do is start out, figure out actually what's the total daily amount that they're going to require. So basically what I'll do is I'll take that 18 kilos and then I'll multiply by that 4 mg per kilo per day, right? So I'll do 18 times 4, and I get 72 milligrams. That's how much they're going to get per day, right? Well, I know this divided BID, so I can just go ahead and divide that by 2. And now I know they're getting 36 milligrams per dose, okay? Well, now that I have that 36 milligrams per dose, I know that my concentration is 15 milligrams per ml, so then I just divide that by 15. Again, pretty straightforward. They're going to get 2.4 mLs. So you would write ranitidine 2.4 mLs, POBID, right? PO being by mouth. It's pretty simple, right? Well, it gets slightly more complicated in some cases here. So let's say we have a patient with cellulitis, and we're going to be writing for the drug trimethoprim and sulfamethoxazole. This is a combo drug, which is frequently, the brand name is Bactrim or Septra. You might see occasionally. This is used for all kinds of things. UTIs, prophylaxis against certain infections, pretty common. What is important to note about these combo drugs is that typically they're going to be dosing it based off of one component. And the reason why they can do that is because this is going to be in a fixed ratio. So for instance, here you see the suspension is 200 milligrams of sulfamethoxazole and trimethoprim 40 milligrams per 5 mLs, right? So this ratio never really changes here. So it makes sense that I can dose off one or the other component, and I should be able to get, you know, that same ratio of drug regardless. And so for this combo, majority of the time you're going to see that the trimethoprim component is what you're actually going to be dosing based off of. So here you can see we have a 12 kilo patient. They're getting 4 milligrams of the trimethoprim component per kilo per dose BID. Okay, now remember what I said earlier is that now I have it, this is in a per dose amount. I don't have to divide by 2. Patient's still getting a BID, but I'm not getting a per day amount. This is why you can be really, really careful when you're looking up drug dosing for these assignments as it comes up, and when you're writing for actual people, that you're conscientious of looking at, is it a per dose, is it per day, what are they actually saying here? Because it's quite easy that if you were to read this as per day and then you divide it by 2, they're only getting half the dose they need. And then maybe you're not treating that infection like you should and it gets worse, right? So this is why you gotta be careful. So anyway, so how are we gonna calculate this out? Well, we're going to start out with saying that, okay, well, I know I have a 12 kilo patient. I know they're going to get 4 milligrams of trimethoprim per kilo per dose. So what I'm going to go ahead and do is do 12 times 4. They're going to get 48 milligrams of trimethoprim per dose, right? They're going to get that twice a day. Now, keep in mind, I don't really care about the sulfamethoxazole because this is just along for the ride with the trimethoprim, so I don't really have to think about that one too much, okay? So now what do I do? Well, I got to figure out what the concentration of my trimethoprim is here, and you can see it's 40 milligrams per 5 mLs. We'll just divide that out to see what the actual concentration is. So 40 divided by 5 is going to be 8. So I know this is 8 milligrams of trimethoprim per ml. Okay, so what I can do is take that 48 divided by my 8 milligrams per ml of trimethoprim, and I'm going to get 6 mLs. So basically this child would end up receiving 6 mLs of sulfamethoxazole and trimethoprim BID for whatever duration they need to receive it for. Okay, again, makes more sense if you get some practice with it. That's what that quiz was for, is to try to get you some practice with that stuff, and the prescription assignment will also be helpful for that as well, as we'll see in just a little bit. Now, we could also do it the other direction too. So before, you're trying to figure out, how much to actually write for, say, on a given prescription. Let's say now that we have the case where you're working in the ER, peds ER, mom comes in, they said their kid's got a fever and, they can't smell, they can't taste anything they're complaining of. You're like, oh boy, got another COVID case, right? Well, you want to do something for that fever, and frequently you'll find that parents may not be dosing their kids appropriately. They may be giving too much, too little. Frequently, if they've only given half of a dose, we'll supplement that by giving the rest of that dose in the ER, depending on the time frame. But let's say the mom brings a kid in, they're 20 kilos, and she says, oh yeah, I've been giving them 2 teaspoons of acetaminophen 4 times a day for fever, around the clock. And you want to know, is this an appropriate amount? Are they given the correct amount for that given patient there? And so you look up in your drug reference and you see that the usual dose is, say, 15 mg per kilo per dose. And the acetaminophen you have comes as a suspension. It's 160 milligrams per 5. If you divide that out, it's 32 milligrams per ml. You can double check me. This is a weird one, but I just know that because I deal with acetaminophen suspension all the time. And so you're saying, okay, well, is this child being dosed appropriately? So what do? Well, first off, you want to figure out what the kid's actually receiving and seeing is if that's an appropriate amount or not, right? So what we're going to do is say, well, I know they're getting 2 teaspoons. And if you recall, a teaspoon is how much? Well, it's 5 ml. So I know the kid's getting a total of 10 mLs. And I'm sure you can hear my 2.5-year-old in the background there. But anyway, so they're getting 10 mLs 4 times a day, okay? And so you can see that 10 mLs times that concentration of 32 milligrams per ml is going to be what? Well, 10 times 32. They're getting, every dose, they're getting 320 milligrams. Okay. So now you know what they're getting. Now we need to figure out what they should be getting based off of what the actual dose is here, right? So basically what I would do is take that 20 kilograms, multiply by their 15 kilos, and what they should be getting, more exact dose, would be 300 milligrams. So mom's giving 320. You say the kid should be getting 300. Is that a problem? Well, probably not, right? If you're within 10% or so, I would say it's probably not going to be a big issue. Even if mom was given like 330, 340, it's probably not going to be a big deal. So it's close enough. So you can say, mom, yeah, you can go ahead and keep giving that dose. It's totally appropriate for that particular patient there, right? And it's easy to remember because 10 mLs, 2 teaspoons, it's relatively easy. Now, real question is, how accurate was the mom measuring that? What kind of spoon was she using? So how much the kid was actually getting, you don't really know, but just given off of the premise of the question, we're going to say that she had a very accurate teaspoon to use there. So the next thing I want to talk about real quickly is fluid dosing calculations. And so this is for IV fluids that you might be giving to a patient, say coming into your ER or your urgent care clinic or wherever the case may be. And so a general rule of thumb is when you're giving this, you will frequently, especially if they're dehydrated, you're going to start up with a fluid bolus, right? So you establish an IV line, you're going to give them a bolus. Usually this is going to be normal saline. There are other ones you can give. We'll talk about at a later date. But for the fluid bolus, general rule of thumb is you're going to do 20 mLs per kilo. Okay. We'll go through some of these calculations here, and we'll talk about some other points. But generally, 20 mLs per kilo is a standard sort of fluid bolus, okay? Next up, typically what you do, and again, the bolus is meant to kind of get them back up to what where they normally should be. It's to rehydrate the patient, fill the intravascular space, and get them kind of back to baseline. You also want to consider maintenance fluids. Maintenance is meant to replace what would normally be lost just due to normal sensible and insensible losses, right? Urine output and sweating and respiration, all that kind of stuff. You want to replace that, and that's what these maintenance fluids do. And so this is where, say, if you were like the admitting person, admitting the patient to the med surg floor or something, this is where you would go ahead and write for them, say, D5NS. So dextrose 5% with NS. We're going to run this many mLs per hour. This is how you figure this out. And this is the 4-2-1 rule. This is a little difficult for people to get at first, probably because maybe I'm not doing a great job of explaining it, but we'll work through it, and then we have some practice ones we can do here to make sure you kind of get the point. So what is the 4-2-1 rule? Basically, it says that for the first 10 kilos of a patient's weight, they're going to be getting 4 mLs per kilo per hour. Okay, and again, this is per hour, so they would be potentially getting this continuously 24 hours straight until whenever you decide to stop the fluids. The next 10 kilograms of their weight, they're going to get 2 mLs per kilo per hour. Okay, that means from kilogram 11 through 20, they're going to be getting 2 mLs per kilo per hour. And then for every subsequent kilogram after 20, they're going to be getting 1 ml per kilo per hour. Okay, and this is how you figure out what their fluid rate should be on a maintenance basis from then on. Sometimes you go above this. Sometimes you'll hear like do 1.5 times maintenance, sometimes 2 times maintenance, sometimes half maintenance. But you got to know how to actually figure out what the maintenance rate is in the first place to understand what those other ones are going to be. So how would I do that? It kind of reminds me of the Parkland formula for burns. Yeah, a little bit, for sure. So this is kind of based off the same things. You'll see, in the case of like a burn victim, like they're going to require a lot more fluids as the case may be. But yeah, this is for general, like patients coming in for gastroenteritis and they're dehydrated, poor PO intake. Like this works for any of them. This could be if you have like a patient who's coming back from surgery and they're going to be NPO for a little bit. You could do these same maintenance rates. This is going to apply to really anyone. It doesn't, not even pediatrics. You could do this for adult patients too, and you will get definitely workable numbers for sure. But let's go through these instances here. So 8 kilogram infant. Okay, well here we only need the 4 part of the 4-2-1 rule to get what their maintenance rate would be. And so 8 kilogram infant, I would just do 8 times 4. And now I know they're going to get a maintenance rate of 32 mLs per hour, right? So really just canceling out the kilograms here, and they're getting 32 mLs per hour. Their fluid bolus would be 20 times 8. So 160 mLs. So, right, so not a ton of fluid here we're talking about here. I'm sure most of you could probably gulp that down no problem. And this is what the fluid bolus is for that particular patient. So quite small amounts here. We'll see that's even more so with the neonate here. So let's say we have 1,200 gram neonate. Last time I talked about this, I accidentally said 1,200 kilogram neonate, and that would have been quite a large neonate indeed. But let's say we have a 1,200 gram neonate. The important thing here is to make sure you're converting it back over to kilograms. How do we do that? Well, we talked about that last time, and you basically just move the decimal place over, 1, 2, and 3. So I know this is actually a 1.2 kilogram neonate. If you did not do that conversion, you would be getting some very large fluid volumes indeed, and would probably drown your patient, right? But we converted it back to 1.2 kilograms as is appropriate. So the fluid bolus for that kid would be 20 times 1.2, 24 mLs. I mean, that's less than an ounce of fluid for a fluid bolus, right? So these are very tiny patients we're dealing with, very small amounts of volume, which is, you can see why it's so easy to actually overdo it and give too much as the case may be. So that would be their fluid bolus. And then again, they only need the 4 part of the 4-2-1 rule. So I just do 4 times 1.2. And then their rate per hour would be 4.8 mLs per hour. Okay. Now to get a little bit more complicated, let's go with a 45 kilogram adolescent who's going to require the whole 4-2-1 rule. Basically what you're going to see is that for the first 10 kilograms of their weight, it's going to be 10 times 4. So that's 40 mLs per hour already. We have 35 kilograms left to account for. So for that next 10 kilograms, it's going to be 2 times 10. They're going to get 20 mLs per 20 mLs per hour. So now you can see already they're up to a maintenance rate of 60 mLs per hour. We still have 25 mLs to account for. So then you'll do that 25 times 1, right? Because every other kilogram after that, the 20 is going to be 1 ml per kilo per hour. So their total rate here is going to be 40 plus 60 plus 25. So that maintenance rate for that 45 kilogram adolescent is going to be 85 mLs, right? Add all 3 of these together, 85 mLs per hour. Their bolus, again, boluses are real simple. It's just 20 times 45, 900. Okay, so there you get a 900. If you round it up to a liter, no one's probably going to fault you for that one. It's a little bit easier because that's how the bags normally come anyway. Okay, let's say we have that linebacker. It comes in. We actually have at Nemours, we have a contract with Disney to where we actually get all their patients are being transmitted via EMS. They get sent over to us or transferred to us, and like the world of sports and all that. Especially during the summer season, ostensibly before COVID happened, we would have a lot of sports competitions and tournaments and stuff like that. So we would get football players and cheerleaders and all kinds of injuries all the time. But let's say we got that 100-kilo linebacker coming in. What's their fluid bolus going to be? Well, basically, again, you start with 20 times their weight. You get 2,000 ml. That's 2 liters of fluid there. Now, in pediatrics, you may find that you would just start off with 1 liter and see how the patient's responding and then give that 2nd liter. Depending on clinical severity, if you want to go and do the full 2 liters altogether, if they're really fluid depleted, if they were, say they were bleeding and they're hypotensive, you may go with that full 2 liters. A lot of times, though, if it's less severe, just do a liter and then see how the patient's responding and go from there. But let's do their maintenance rate. So again, here we're going to see for the first 10 kilos, it's going to be 10 times 4 mLs per kilo per hour. So it's 40 mLs. For the next 10, it's going to be 2 times 10 kilos, be another 20. And then what do we have left over? We still have another 80 kilograms to account for. So I'll do 80 times 1, and that's still 80. So you can see here the maintenance rate for this patient would be 80 plus 20, which is 100, and plus 40. So 140 mLs an hour would be the maintenance rate for that particular patient. So hopefully that makes some sense. It was fairly straightforward in terms of that, but you got to remember how to do that, because if you can do this on rotations, like from day one, you'll probably be far ahead of a lot of other students you'll run into. Our NOVA students are ahead of most other students anyway, but you will certainly see that. So one other thing you might run into, especially if you're in the OR or say you work in the ER, is you may find drugs being expressed as percentages, right? So you see lidocaine, which is a local anesthetic. It may be expressed as 1% lidocaine. You're like, well, what does that 1% mean? Well, basically what it means is it's 1 gram per 100 mLs. And you're like, well, that doesn't really mean much to me either. A handy tool you can use, or handy trick you can use, is anytime you see something expressed as percentages, if you just move the decimal place 1 over to the right, you will then get that concentration as milligrams per ml. Now, milligrams per ml, I can certainly work with. That's what I was doing for all those other PEDS calculations. So that's really handy here. So let's say we have a 24-kilo patient. They need to get intradermal lidocaine. They had a laceration to the face. Maybe there's like a dog attack or something like that. You need to suture it up. But you want to numb up that tissue first with some lidocaine. And let's say the max dose they can give is 5 milligrams per kilo. So how many mLs can you use in that patient, right? That's a good question to ask, because you want to use too much because that can lead to issues. You want to use too little because that can lead to their face not being all that anesthetized and can be more painful for the patient. So, but you got to know that trick there. You got to know how to convert that 1% over into a usable calculation, a usable concentration. So again, move it 1 over to the right, 10 milligrams per ml there, right? Okay. So I'd say it'd be 1 ml per gram. No, so if the actual definition here, if it's 1%, it's 1 gram per 100 mLs. But when I do this trick to move it over 1, it'll be 10 milligrams per ml. Okay. So let's say we're going to do this. We know the max that the patient gets is 5 mg per kilo. So I can just do 5 mg per kilo times their weight, which is 24 kilograms. I know the max they can get is 120 mLs. Or I'm sorry, 120 milligrams of lidocaine. Now that I know my percentage, though, if I had 1% lidocaine is 10 milligrams per ml, then I know they can get a total, divided by 10, of 12 mLs. So you can inject a total volume of 12 mLs into that, in and around that laceration to numb it up. But what if you had 2% lidocaine? Well, 2%, you do the same thing. You just move it 1 decimal place over, and it's 20 milligrams per ml. So instead of using 12 mLs, I can only use 6 mLs, right? You can double the dose of drug in there in half the volume. Maybe that is more appropriate for certain areas where maybe it can't really handle a lot of fluid potentially. So just something to think about. You will not run into this too frequently, but it happens enough to where you at least want to know that trick so you can help do those conversions. This works too for things like D50, like dextrose 50%. Just move that 1 decimal place over to the right, and then you know it's 500 milligrams of dextrose per ml. That can be really handy if you know that I'm dosing, say, half a gram per kilo for a patient or something. You can do those calculations more easily then. So a little handy trick. So if any questions on that, please let me know. Let me see. I think there's a question here. Ooh, this is a good one. Okay, I have a few questions on here. So, as PAs, are we expected to be able to calculate doses? Absolutely. Of course, you got to be able to calculate doses. You do this when you're writing prescriptions. You do this when you're writing orders. You may be lulled into a false sense of security because you may have a computer system that does most of this for you, but you still got to be able to know how to do this. You got to know the underlying math behind it. So, absolutely, you guys are expected. There's a lot expected out of PAs, and so you're going to be well prepared for that by the time you graduate from here. And so, okay, we'll talk about the drug assignment a little bit later. Let me see. A lot of examples of specific medications in the PowerPoint. Should we know them for the exam, or we'll be asking more concept-based questions? For the exam, it's going to be more conceptual. So I'm not going to ask you specifically like what kind of drug epinephrine is or albuterol or something like that. It'll be more conceptual. I may mention drugs and talk something about them, but the concepts are what you need to know there. So that's going to be the important thing with that. Okay, let's see. So I'll talk about the drug prescription assignment just a little bit, but let's go ahead and get into the next thing about therapeutic drug monitoring. Okay. So unit 6 here, and I'm only almost 40 minutes in. So, okay, let's continue on. So what is therapeutic drug monitoring? Well, basically this is where we're measuring blood levels of drugs and then basically determining, are we dosing this patient appropriately? Do they have enough drug to be effective? Do they have too much where it's going to cause toxicity? Where are they at? And so two terms we're going to use here include our peaks and trough. Peaks just basically means what's the highest concentration that drug is going to achieve after a dose. So you can see here you have a peak effect, and then you will see that the trough is going to be the lowest amount before we end up giving the next dose, right? Because again, typically if you're dosing drugs at a steady state level, you will not reach level 0 before that next dose, right? Because of that dose stacking effect that occurs. So here you would see, for instance, if I gave a dose of drug, I get the peak effect, and then the trough would normally be right when I'm giving that second dose. But let's say I missed the dose for whatever reason, then I can go down to here, and this would be my new trough until I were to give the next dose. But typically you'll see that when you're at steady state, the peaks and the troughs should be consistent. Assuming you're given the same dose, the same intervals, you should see that there's that constant sort of vacillation here. It looks like a perfect sine wave almost based on how much you're given and being consistent like that. And so if you recall, we said that there was different ways to achieve the same steady state. I could give a large dose less frequently, but we saw that it had some problems. Maybe you get the levels too high and cause toxicity, or the levels too low leading to inadequate effect, right? I could give a continuous infusion, but again, that's going to be pretty difficult to do, especially if a patient is not in the hospital, right? Because it's going to be difficult for them to carry an IV pole all the time. So what you may have to do instead is to try to achieve sort of that Goldilocks sort of in-between state there where you're at just the right levels, is to give a smaller dose more frequently, as you can see with this sort of light gray line here. See how it mitigates the peaks. The peaks are lower, but also the trough is going to be a little bit higher based off of that. And so for some drugs, it doesn't matter. You can do this large dosing strategy, and that's no problem. For other drugs, you may need to require this. And a lot of that's based off that therapeutic index for the drug itself. If you recall, the time to steady state is roughly 4 to 5 half-lives. That's a good, handy rule to remember. And this is important because what we're going to find is that when we're doing blood levels, you don't want to do these things too early. What happens if you do it too early? Well, you may falsely think that your levels are too low, not realizing that the patient's not reached a state of equilibrium yet. You got to make sure you're at steady state before you start doing these blood levels. And we'll talk more about that just a little bit. So, what is clinical pharmacokinetics? Well, this is basically where we are applying our pharmacokinetic principles to try and make sure that we are achieving safe and effective therapeutic management of these drugs. In individual patients is the thing too. So again, when you look at your drug references, you look at your individual drug and you look at all those pharmacokinetic parameters, that is based off population averages. Well, is everyone average? Well, no, there's always going to be outliers. And so this is how we take those population averages and then apply it, and seeing how the patient themselves respond in terms of their blood levels and in terms of their clinical response, then individualizing that strategy and that dosing for that particular patient, right? So that's where a lot of that critical thinking and being able to take things from a drug reference and then saying, okay, well, that's usually how it is, but for my particular patient I'm dealing with here, they are not responding that way, and how can I adjust things to make sure that they get the maximal response while trying to mitigate that risk for toxicity there. And so we're going to use the term therapeutic drug monitoring when we're using the serum drug concentrations and using those principles of pharmacokinetics and also dynamics here to try to optimize the patient response to drug therapy. And so frequently, and this is a favorite of Professor Kaplan, but they'll always say vancomycin, pharmacy to dose. That's what we're doing, is we're doing that therapeutic drug monitoring. But you may be working somewhere where you don't have pharmacists that are nice enough to do all that dosing for you. So you may need to know how to do some of these things here. And so we'll talk about the concepts behind this now. We won't necessarily get into all the details of it because it's a little bit outside of our scope at this point. But what I want you to understand is sort of what are the benefits, the limitations, and how we might actually apply this in order to, sort of obtain and interpret drug levels and how that helps us with our decision making. So early, what we used to do this for was basically to try to determine what our therapeutic range is going to be. And some of you may have noticed this in your drug assignments. You may find that there was a therapeutic range where you say, okay, well, this is, you want to at least get to this level to be effective, and then you want to go above this because that's when a lot of side effects pop up. And since then, we've been able to figure out better ways to individualize things for a given patient based off of those kinetics in that particular patient. And again, when we talk about therapeutic range, we're talking about that range between sort of the effective dosing all the way up to where we're going to see the maximal sort of therapeutic effect, and then comparing that to the toxic effect here. So for instance, if you're looking at this range here, you would see that we get the therapeutic effect up to a certain point. Again, this is the number or percentage of people responding, right? And again, you get to a point, you got to figure out kind of where that right point is for you, where you're going to get, most likely you're going to get efficacy out of that drug, but you don't want to get so high up on this toxic range here that you're going to accidentally cause a lot of issues for your patient. And this overlap may be near 1-to-1 in some cases. You may find it's going to be very wide depending on the drug here. So for instance here, by the time you get up to a point where almost everyone is going to be efficacious, you're going to find that many people are going to be having toxicity as well. So this range can be pretty narrow depending on the drug that we're talking about. And again, there's another way of looking at something like a wide therapeutic index. How there's almost no overlap at all. I'm getting to a point where I'm dosing and 100% of people should be responding. You notice here there's no overlap with the toxic side effect curve, right? Versus something like this where there's a lot of overlap. There'd be a very narrow window in which we're shooting for, to which we're trying to mitigate toxicity, but trying to maximize our efficacy. So this is kind of that Goldilocks sort of range here. Where if we're on this side, we're less likely to get efficacy. If we're on this side, we're probably going to be effective, but likely to get a lot of side effects. So you're shooting for this very narrow window. And so when we're doing this, we're looking at the actual pharmacokinetic variability in that particular patient. How we do that is by actually measuring blood levels and seeing how they're going to respond to it. Because you can look in a book and it says, start off by dosing this patient 10 mg per kilo per day. You do that, and then you get levels that don't correlate with what was actually in the book. Now, why is that different? Because that book was using a lot of population average kinetics, but your patient is different than that, right? Everyone is their own little special snowflake, right? I don't mean that in a derogatory sense. It just means everyone's going to have a little bit different way that they're actually going to be processing a lot of these medications here. And then again, looking at that pharmacokinetic variability, you'll find that you'll get a varying concentration at the actual site, and then that leads to those actual effects that we're looking for. And again, you can see there's a ton of different things that are going to be affecting both the kinetics and the dynamics, how these drugs are going to work, and why you get so much variability. You can give a given dose of a drug to a patient. You've given it to 100 patients. You say, wow, this dose works good for everybody. You give it to that one person, and they react totally differently. Either they get no effect whatsoever, or they get way too much effect. A lot of it goes into all these different factors here, which we'll talk about at varying points throughout our talks in pharmacology and all of that. But this is why we have to do things like therapeutic drug monitoring, especially for drugs that have those really narrow therapeutic indices. And so what you're going to find is that TDM really applies to a relatively small number of drugs. However, a lot of the drugs that we're using these for are like really frequent movers. We're going to see that we're using these drugs quite often. And so that's why we talk about this, because it is pretty important, especially depending on where you're working in terms of specialty. Are you going to do a lot of therapeutic drug monitoring if you work in dermatology? Probably not, but if you work anywhere in the hospital, you're going to definitely run into this. Even urgent care, a lot of different places you're going to run into this. So again, this is why we cover it, because we want to make sure that anyone that graduates from here knows at least what this is and how it might be applied. So, like I mentioned, it really only applies to a small number of drugs, because many drugs we just have a direct measure for how it's working. So, for instance, with like a blood pressure medication, well, I don't have to measure a level of the drug to know if it's working. I can just measure your blood pressure. Similar for things like cholesterol medication. I can just measure the cholesterol and know how well it's working. Or, for instance, like warfarin and PTINR. I know if it's thin in the blood because I can look at the PT-INR. I don't really care what the warfarin level is. I care about what that INR is to see how anticoagulated the patient is and how likely or not they are to maybe develop a clot and and cause a stroke or something like that. So there's some assumptions we have to make when we're doing TDM for our patients here. And so one of which is going to be that by measuring the concentrations, it gives us the opportunity to sort of adjust for that pharmacokinetic variability. So basically by measuring those levels, then we can change the dose. We can change the frequency that we're giving it to try to individualize that for that given patient. And then that the drug concentration can be a better predictor of response than the dose itself. So for instance, you may have 10 different patients, you give the same dose to them, and even though they're all similarly sized, you would find various effects. Some people get a lot of really good effects, some people don't, some people get toxic from it, and so the dose isn't really a good predictor. This is where drug concentrations may be better, and that's one of the assumptions we're going to use here. And there should be a pretty good relationship between drug concentration and pharmacologic response, such that if I increase the dose, I should expect to see more of a response, and vice versa. So when you're looking at that drug response, again, there are some things that we can change and some things that we shouldn't. So just like they say, give me strength to accept the things that I can't change, and the strength to change whatever. I don't know the actual stuff. I don't go to AA anymore. Just kidding. But basically, the clinician does not control is bioavailability and clearance, right? Because this can change from day to day by the patient, but I can't do anything for that. Versus dosing in the interval, I can certainly have a lot of effect on that. So I can give a different dose, I can change the interval, I can give it less often, more often. So we have total control over this, but this has to factor in for what's changing here. So for instance, if I have a patient who is admitted to the ICU for sepsis, and then all of a sudden their creatinine clearance goes from 100 to 50, that clearance has now gone down by half. I need to make sure that I'm adjusting my dose and interval to account for those changes, okay, to get the same exact exposure as they would have the day before. So when I say a therapeutic range, this is not absolute. This is based on probabilities. This is based on averages, right? Most people are average. That is what average means. And we'll learn all about that in EpiBio. So I'm sure you guys can't wait to take that class, but it's really fun. I promise. And so when you're looking at that range of drug concentrations, we're saying that this is the probability to where we're likely to get a good clinical response and we're unlikely to get toxicity, or relatively low probability of that, right? And so again, this is kind of this narrow range between these two that you're shooting for. And the thing is that people will fall outside of this all the time. You can have people who the levels are too low, but they're having good response to the drug and they're not having any issues. Well, should I change the dose because the level's too low? Well, not necessarily, right? Or if the level comes back too high and the patient is having good effect and they're not having any toxicity, do I need to change that necessarily? No, they could just be outside of the normal. And so the key mantra here, and you're going to see this all the time from everyone, but it's really true, is you treat the patient, not the number, right? So getting this number in a vacuum doesn't really do you much good. You have to look at the clinical situation, right? So if I'm dosing a drug, say for an infection, and I get the level back and it's a little low, but the patient's fever is going down and their white count's going down and clinically they're improving, you may not need to adjust it, right? You may not need to do much with that because they could just be some small subset of people that fall outside of that normal, right? So some other considerations too, we're going to see that when that therapeutic range was initially established for a given drug, it was probably done in a pretty small sample size, right? And sometimes it's even hard to find the original studies where these sample sizes were done or where these actual studies were done. And so it's really important to know who the study population was, because if this was if they established a therapeutic range based off of 100 men back in the 1950s, well, that may not be super applicable nowadays. And so because of that, it's sometimes important that these things change, and you'll see that as time goes on. So typically when we're shooting for a target concentration, and you may see this where a given therapeutic range for a drug is 10 to 20 mics per ml, for instance. When you're looking at that, you typically, if you're shooting for a given target, you want to go right in the middle there. So you can say, well, I don't want to shoot for 10 to 20, I'm going to try to shoot for 15, and that's how I'm going to calculate my given dose. And here you're going to see that you're assuming initially the patient behaves like a normal average member of the population. Normal is not a good term to use, but an average member of the population here. And then we're going to be using average pharmacokinetic parameters to try to estimate what that good dosing regimen is going to be for that patient, right? So for instance, if I'm trying to dose the antibiotic vancomycin and I have a patient who is a typical adult patient, I know that based off of them having typical average kinetic parameters, I can figure out what a decent dose is going to be. I'll dose 15 mg per kilo and then go with that, right? And you'll find this in all of your drug references. So you can look this stuff up and see those there. So once I start that patient on that dose, I'm going to go ahead and give them several doses, and I'm going to wait till they get to steady state. And the question is, like, why do I wait to steady state? And again, this goes back to looking at those concentrations. The point is, and again, how many half-lives does this take? Well, it's roughly 4 to 5 half-lives. If I say I'm dosing this medication and it takes 4 to 5 half-lives, and let's say I'm finally at the steady state, and again, maybe this is just a part of a dinosaur I'm drawing perhaps, but if you end up getting your levels too early, let's say I'm looking for a trough level and I get this early, you're going to think it's kind of falsely low. You may not know it's falsely low, but you may think it's too low, and you're really just getting it too early. So I see a lot of practitioners, especially new practitioners, they'll go ahead and they'll order a trough level after like one dose of a drug. And then they think, okay, well, it's too low, I got to go up on the dose. Not realizing this is not at steady state yet. You have to give it time in order to make sure that you're measuring at the appropriate trough level, for instance, and figuring out, okay, this is a more accurate level. I know this is too high or too low based off, whatever range I'm shooting for here, right? So based on based on the level you get once you're at steady state, and again, very important you do that, you can have two scenarios here. So one, scenario A, you get an adequate response, and you just continue treatment. Everything is good to go. Or in scenario B, you see that the response is either too low, maybe if they have an infection, maybe their white count's not changing, maybe their fever is getting worse, or if they have some kind of toxic effects, like for instance, their kidneys take a hit, or they develop some other toxicity. At this point, this is where I need to either manipulate my dose or my interval in order to get back into that therapeutic range. And so some reasons to use drug concentrations here is because, again, they're providing additional information to be used in conjunction with other clinical data, right? You're using the number, that level, in addition to all the other clinical parameters you're seeing in the patient's status to make a decision. And, there's nothing worse than when a provider orders a level for something, and I'm like, well, why are you ordering a level for that? We don't even know what the therapeutic range is for that drug. And they say, well, I just want to know. Well, it's not really good, right? Because you're not really able to use that information to any real purpose, right? You never want to order a level for something or a lab unless it's going to have some effect on your treatment strategy, unless you're going to make a decision based off of that. Brian's asking, so steady state is achieved within 4 to 5 half-lives after consistent dosing. Yeah. So if you're giving the same dose, the same interval, 4 to 5 half-lives later, you should be at steady state. Okay, assuming you weren't giving it so far apart that the level goes down to 0, for instance, because then your steady state really isn't achieved there. But so again, when we do this, we're trying to do this on the basis that we can individualize that dose for that particular patient there and individualize that regimen. So when looking at if we're determining if changes in kinetics have occurred here, what we're looking at is going to be things like physiologic status. So perhaps their kidney function has changed, liver function has changed, or maybe there's something else going on too. Like maybe they have like a drug-food interaction, or there's an herbal interaction, which is maybe causing liver enzyme induction or inhibition. Something is going on here to where these kinetics have now changed. We want to try to figure out what that is. And two, we might do levels to figure out adherence, right? So are they even taking the drug in the first place? So for instance, if I have a patient who comes in and they're seizing in the ER, well, one of the first things you want to do is figure out, well, what do they normally take? Assuming it's not a new onset seizure. And you say, okay, what does this patient normally take? You find out it's the drug phenytoin, for instance. And you can measure a level of phenytoin. If that level is 0, then I know that patient has not been adherent to the drug, or something has happened where they have a level of 0, and this is likely why they're seizing. So we will go ahead and bolus them with a dose of phenytoin, right? Get them back a steady state with a loading dose. However, if they were to have a level of phenytoin done and that was in the therapeutic range and they're still seizing, that's a whole nother story. That's where we may need to consider adding on a different drug or adding on something because that drug is now not working, right? So adherence is another important thing to consider too. So what are some reasons to request drug concentration? Well, if we think toxicity is occurring, we can look to see if the level is too high or not. If we're not seeing a therapeutic response, this may also prompt us to go ahead and do that. Again, if we want to see if the patient's being adherent, they're actually taking it or not, that can be useful. If we're assessing, maybe we've changed the dosing regimen, maybe the interval or the dose, we want to follow up and see where they're now at, if they're in the range or not. Changing clinical status, this is very common, especially like in ICUs where things like renal function will change from hour to hour in some cases. Or if we're looking at potential drug interactions to see if something maybe inducing enzymes, inhibiting enzymes may have done something to change those levels there. And so some of the information that's required to interpret these drug level. So you order a level, it comes back. You need to know kind of some surrounding information. And so a lot of that has to do with time as well. So we're going to see the time the blood sample was taken. We also know the time that the dose was given too, right? And so this is where nursing documentation is super, super important to know that they are documented, because it's typically nurses who are doing this stuff. Got to know, or so they go to a Quest Labs or something like that. You got to know when this timing was done. So for instance, I've had cases to where a nurse will give a dose of a drug, realize, oh yeah, I was supposed to do a level. It's supposed to be a trough level, and then they measure it right after they give that dose from the patient. All of a sudden, the level looks like it's coming back super high. And you're like, oh my goodness, this patient's not clearing this drug at all. And then we dig in a little further, you realize, oh, actually, the dose was, or the sample was taken right after the dose was given. Yeah, of course, that's not going to be accurate. I got to redo it now. But that's really important to know. Dosing regimen, you want to know the patient demographics, their age, their weight, all that kind of stuff you want to know. Concurrent medications in case there's any interactions. The reason you're monitoring, so is it because the level's too high, too low? And again, too, if you think about it, you might be interpreting levels that you never ordered in the first place. So let's say you're a PA working the night shift and you're taking the reins from someone who's working the day shift. They ordered a bunch of stuff. You get all the results back, and now you got to do something with it. You want to know why that person was doing that monitoring in the first place. Was it because of suspected subtherapeutic effects or toxicity, etc.? And then again, you want to know what that therapeutic range is going to be for that particular drug, right? So some common drug characteristics you'll see is that a lot for these drugs that we'll do therapeutic drug monitoring on is that frequently they don't have like a clear observable therapeutic or toxic endpoint. So it's kind of intermediate between these two, where that sort of that gray area between getting good therapeutic effects and those toxic effects is not clearly delineated between one another, and it's very easy to slip from kind of one to the other. And you'll see the concentration should be a good surrogate for the concentration at the site of action. So for instance, if I'm dealing with a pneumonia and I'm giving an antibiotic for that, well, I'm not going to measure the level of antibiotic in the lungs. I have to measure it in the blood, and I have to know what that correlation is between blood levels to lung levels are going to be in order to get a good idea of if I'm at a good range or not. As I mentioned, with the narrow therapeutic drugs, you're going to see this. They frequently have variable pharmacokinetics. So the most common ones I do kinetics on are going to be water-soluble antibiotics, things like vancomycin and your aminoglycosides. I'll show you some examples of those in a moment. But they are entirely dependent on renal function, and so if the renal function changes, now all of a sudden you're going to have a patient who's handling those differently, and we have to account for that sort of thing to keep them in the range. Okay, and if the drugs were completely safe and there was no toxic issues with it, then why would we care? We wouldn't really care what the levels are. We dose it to whatever would get us therapeutic effects. But frequently, you're going to see toxicity associated with these, right? For instance, if I'm dosing too aggressively with my gentamicin, I can cause kidney injury. I can cause ototoxicity and cause hearing loss. Or if I'm not dosing aggressively enough, I can lose that efficacy, and maybe that infection is never treated, right? So this is why you're going to see we do this, is because of the risk associated with them. And then they should have fairly stable pharmacologic effects, such that if you're in that range, they should be doing their thing and working as effective as they would for any other patient. So, and then when we have these assays, we want to make sure that they are going to be accurate, precise, and specific. So, it may sound like kind of a known or kind of like a no-duh kind of thing, but this is important too, because sometimes you'll have things that cross-react with other things. So as an example, if you do a urine drug screen and you do, say you take a dose of pseudoephedrine because your sinuses are bothering you, you may pop positive for methamphetamines, because pseudoephedrine looks enough like methamphetamines to the assay that it cross-reacts, right? So you want to make sure these things are accurate and very precise for the substance you're actually looking at. And then you also want to make sure there's a reasonable turnaround time and it's relatively inexpensive. And so, you can get a level for anything, really, right? You can do GC mass spec for any drug, but if it takes you 2 weeks and it costs you $1,000 to do, it's not all that efficient with your resources. And so frequently we're going to do levels on drugs that you can do in-house, or they can do at a typical Quest Labs or something. So it should be available within a short period of time, relatively speaking, and then be relatively inexpensive to get. So for instance, if I get a level of a antibiotic in the hospital, I can expect that to come back within a couple of hours, right? It should be, again, if it's done in-house, pretty inexpensive. So what are some commonly monitored drugs we would do this for? Well, this can include things like our anti-infectives, not all of them, but just a few select ones. Most commonly, you'll see like vancomycin, which is really good for like gram-positive bugs like MRSA, we're going to use this quite often for, and then aminoglycosides like gentamicin, which I mentioned in the PEDS lecture, and then tobramycin, for instance. If you deal with cardiovascular drugs, things like digoxin, you're going to do this quite often. Don't memorize this list by any means. I'm just showing you some examples of things and areas where you might use this more commonly. Antiepileptic, so if you work with neurology, or say you work in an ER, you may see these drugs and do these levels pretty commonly. Or immunosuppressives, if you're dealing with transplant medicine. In order to keep patients from rejecting their organs, you may use certain drugs to try to suppress the immune system. And so, again, that makes sense too. You can imagine if you suppress the immune system too much, what are you at risk for? Well, you might get a lot of infections that can happen from that. So you can see there's kind of that range there where I want to make sure that I'm suppressing the immune system enough to not reject the organ, but also not so much I'm going to cause them to have an infection, right? There's not that clear delineation between the therapeutic and that toxic effect you're going to see there because they're all in that same spectrum. And so, what are my limitations to doing this? Well, cost can be one thing, could be relatively expensive. Although I will tell you that, not to toot our own, professional horns, and actually there's a lot of evidence to show that if you have like pharmacy-based therapeutic drug monitoring services, like especially in hospitals for anti-infectives, it actually does reduce costs because you can actually make sure patients are in the therapeutic range for longer and prevent adverse sequelae like, nephrotoxicity and stuff like that. So you can have a cost savings here, but sometimes you may find this could be a limitation. Drugs have a really wide therapeutic index. You don't really need to do therapeutic drug monitoring for that because, again, it's so wide, I can give relatively any dose to a patient and not really run into too many issues there. Sometimes you may find there's not a good relationship between the concentration and the response you get, in which case getting a level doesn't really tell you a whole lot, or if there's not like any reference data available. You can get a level, but if you don't know what a normal range is, then it doesn't really tell you anything. It may just tell you whether the patient's adherent or not to the drug. And then if they have a direct response measure, then just do that instead. So if I'm, for instance, dealing with something that lowers blood pressure, just measure the blood pressure. I don't need to measure the level, Sometimes it can be tough too, though. If imagine you've had someone with epilepsy, they're not going to have seizures all the time if they don't have any medication on board. It's kind of one of those things that just happens, not completely at random, but it seems so. And it's one of those things where, you can have the drug on board, and you can have it at therapeutic range, but you don't really know if it's being effective or not. You only really know if the patient has another seizure. And so that can be really important for patients to do things like have like seizure journals, or where they actually mark down how often they're having seizures. And that can sometimes be useful to see how well the drug's working. So some inappropriate uses, just getting routine levels just because it makes you feel better is never a good reason to do something. So if you know that they're in the therapeutic range and there's no reason to suspect that level has changed, then don't get another level. You don't really need to, right? Should you get a concentration for patients that are responding appropriately? Well, if there's no risk for toxicity and they look like they're appearing to improve, then you may not need to do anything like that, right? As I mentioned, if there's no apparent change in patient-specific kinetics, so their renal function is staying rock steady and their liver function is good and their VD is fine, you may not need to get a level there, right? Or as I mentioned, samples taken at incorrect times. It can be really a problem where you get those levels that come back super high, and it's because the nurse gave the dose and then took the level as opposed to the other way around, and then you have to basically wait until the next dose right before then, and then you have to get another level. So again, it's incurring extra costs, and then it's delaying your time to actually make a decision. And so by doing this, the benefits here is that we can reduce the number of patients who become toxic. We can help more patients get into the therapeutic range more quickly, and then basically help to save costs and mitigate. If I don't have to have a patient develop an iatrogenic renal dysfunction, that's good for me because, again, if you look at insurance companies, they're not going to pay the hospital for giving the patient kidney injury and all of a sudden they need to go on dialysis or something. So this is why we do this, because it has really good benefits. And this is as compared to patients without therapeutic drug monitoring, if they're just getting flat doses based off of just population kinetics. Other things we're going to see: improved efficacy, reduced toxicity. In some cases, you can actually have decreased length of stay, which is good because you get more patients going through the hospital. And we're going to have more rational use of drug concentration measurements. We're not just measuring things because it makes us feel better. We actually have an agenda when we do so, and we know what we're going to do based off of that level. And overall, it tends to be cost effective when done appropriately. So what are the actual steps here? What am I going to do? Well, first off, you want to figure out, okay, is this a routine monitoring thing or is it a specific indication? So is it because, I'm having a lack of response? Is it due to a side effect at a therapeutic dose? What's going on here? And then look at the blood sample collection. So was this done at the right time? Did I even have the right collection tube? So I'm not sure if you've hit this in Clin Lab or not, but there's a variety of different tubes. There's tiger tops and red tops and green tops and all kinds of different tops. I couldn't tell you the difference between them, but I do know that the nurses who are drawing those levels, or whoever is doing the levels, or be phlebotomist or whoever, they know that stuff pretty well. But mistakes happen, right? There are some cases where they actually have tubes that are lithiated, meaning there's lithium in them. Well, what would happen if I got a lithium level in a tube with lithium in it? Well, it's probably going to come back really high, right? So that's not a good idea. Or some of the tubes are heparinized to prevent blood from clotting, and if I'm measuring something like how well my heparin's working, well, obviously that's not going to throw the measurements as well. So you got to make sure the right collection tube. So this is another thing too. You'll see if a level just doesn't look right, it probably isn't. So you really just want to make sure that you go back and double check to make sure everything was done appropriately. All right, so let's see. So just to clarify, TDM is based on the patient's own levels, whereas patients not on TDM would just have medications based on general population data. Yeah. So, for instance, if I was dosing like vancomycin and it said just do 1 gram Q12, and I just gave a patient 1 gram Q12 and never checked a level, they would likely be at more risk for developing toxicity, or they may be more likely to not have sufficient levels to treat an infection, versus if I have someone who I started on 1 gram Q12, waited for them to get to steady state, checked the level, saw where they were, and then adjusted based off of that. Right, so that's the kind of the difference between those two paradigms there. So then you look at the laboratory measurements, make sure that was done appropriately, and then you're communicating the results, right? And the units can be super, super important here. So wherever you work, if you're working in a consistent place, they'll probably report things out in a certain number of units, but it can change. So I run into this occasionally at the poison center. So when I take call for the poison center, I basically am the on-call person I do it for the Jacksonville Poison Center. And so basically I'm responsible for anywhere from the Panhandle down to just north of Orlando, right? So any hospital can call up, and if they want to talk to a toxicologist, they talk to me basically when I'm on call. And so I remember I had one case where there was an aspirin overdose. And normally when you report aspirin levels, it's in milligrams per deciliter. That's how I'm used to normally hearing it. And so, a level of like 40 is high milligrams per deciliter. A level of 100 milligrams per deciliter is potentially fatal. Okay. So anyway, so I had this nurse that was talking to me, and I said, well, what was the aspirin level? And she goes, oh, it was 400. I go, oh, okay, well, when's the patient's funeral happening? Because there's no way that's not compatible with life. And she's like, no, the patient's doing fine. They're breathing a little heavy and, a little feverish, but they're otherwise doing fine. As I said, like, okay, well, there's not a correlation there. So what units are you using? And they go, let me look it up. And they looked it up. Micrograms per ml. I was like, aha. So micrograms per ml is very different than milligrams per deciliter. So once I did the conversion, they actually had a level of 40, and that's much less scary than a level of 400, right? So units can be quite important and something that as students, you're more likely going to skip out on. You're going to gloss over the details, but I swear they do come up clinically more often than you think. So then you're looking at the therapeutic management. You're going to take the clinical picture into account. Is the patient getting worse? Are they getting better? And then you decide to optimize the drug treatment. So typically you're going to be modifying the dose, the interval, or in some cases you may do both. More often than not, it's going to be dose or interval. I typically don't do both unless there's a really good reason to do so. So I either go up or down on the dose, or I go up or down on the interval, either giving the drug more frequently or less frequently. And then you wait till the patient gets to the new steady state based off of the new dosing regimen, give them 4 to 5 half-lives, and then you rinse and repeat. Start the process all over until they're in a good therapeutic range. So a lot of the things that factor into these differences in kinetics on an individual basis may be related to pharmacogenetics. And so this is something we're going to be doing more studies on as time goes on, because TDM is really reactive. It's like I give a standard dose of drug to a patient, I get the levels back, and then I react to that. And then I get that new level, and then I react to that. Well, what if I could be more proactive? And what if I could be looking at a patient and their genetic profile, have an idea of how well they're going to respond or not respond to a given drug there? And so that's why in the future you may see more of the sort of pharmacogenetic guided TDM. And so this way I can take a group of patients and try to identify which ones are more likely to have good response, which ones have maybe no response, and maybe which patients are going to be more likely at risk for toxicity based on individual polymorphisms. Maybe it's related to liver enzyme expression, maybe it's related to renal transport protein expression. All kinds of different things could be playing a role here. And so instead of going from, say, drug A to B to C to D, back to D, and just kind of trialing things out, or trialing different doses. Instead, I can be able to individualize it right away, maybe do a lab test and say, okay, you need to go ahead and start at this particular drug level here. And so you'll hopefully see more of this as time goes on. So let's do an example of a therapeutic drug monitoring case. This is an example that happened to me at one point. I think this is when I was on rotations in school, so it was quite a while ago. Unfortunately, I'm getting older and older as it turns out. But we're using the drug digoxin. This is an antiarrhythmic we will use frequently for patients with either CHF or AFib in a lot of cases. But let's say we have a patient who's been on the same digoxin dose for 15 days, is seen in the clinic, and is found to be doing well clinically. You get a digoxin plasma concentration drawn that morning of her visit, and its report is 3.4 nanograms per ml. And I know the therapeutic range is 0.5 to 2 nanograms per ml. Okay, so it looks like the level's too high. The patient looks well clinically, though. So what are some possible reasons why this level might be elevated? So the question is, like, when was the dose taken? Like, these are things I want to ask the patient or ask the lab. When was the dose taken? When was the blood actually drawn in relation to that dose? And what is her normal dosing regimen? When does she normally take her medication? How often does she take it? Have there been any changes to this that maybe you don't know about? If you're the family practice person and you're following up on her, but her cardiologist is the one that changed the dose, then you may not have heard about that, right? And then whether or not they're experiencing adverse effects. And so for digoxin, certain things you'll learn about would be things like, okay, they see halos around lights, they get this yellowing of the vision, that's called xanthopsia, and they have a lot of nausea and vomiting associated with it, right? So you want to ask the patient specifics related to that given drug. Are they having any of these effects here? And so when you're looking at that, you remember that, steady state dosing here is based off the bioavailability of the drug, based off the dose you're giving, over the clearance in that dosing interval, right? So the bioavailability, is the patient absorbing more than average? Well, I would doubt that, but there could be some instances of this. So for instance, some drugs that are affected by PGP, if that was inhibited, we know that will lead to a higher bioavailability and higher blood levels, right? Is the patient taking more dose than prescribed? Maybe they're absent-minded, or maybe they have dementia or something like that, and they're taking more than they need. That could be a reason why the levels would be too elevated. From the clearance standpoint, has their clearance gone down? Has that led to this high CSS? Digoxin is renally eliminated. Has their kidney function changed to lead to this high level? Or the dosing interval, is she taking it more frequently than prescribed? Maybe someone told her to take it, she's supposed to take it Q12, but then she's taking it Q8, for instance. These are all reasons why the level might be too elevated that you need to try to hunt down and find out what's going on here. There also could be an error with the assay. Maybe the assay was done inappropriately, or maybe there's some kind of interfering substance, or maybe some rare instances where maybe there's a drug-drug interaction or drug-herbal interaction where it actually looks like the other compound. It looks like digoxin to the assay, and they can't tell the difference, right? So there could be a number of reasons here, some of which are more likely than not. So for instance, the likelihood of an older person having their renal function go down is probably higher than them having an assay error, for instance, but it just depends, and all things you want to look up. So anyway, so what do you do now, right? Now you have this high level. There's nothing obvious, but you want to confirm the sampling time, right? So you can call the lab and figure out when it was done. Determine how adherent the patient is. Did they maybe forget the last day's dose and then they doubled up today, and that's why the level's high? You can ask for things like that. Look for concomitant substances. Are there herbal products that they're taking? Are there other drugs they're taking maybe that aren't on their medication list that they have not told you about yet? And then sometimes you just repeat the sample. Sometimes if things don't look right, it's okay to just say, okay, well, let me just try to start over and just get another sample to see what's going on here. And that can sometimes give you some information. And then determine bioavailability and clearance, right? So for that patient, if it's renally eliminated, well, I can go ahead and get the creatinine clearance and try to determine has that changed from her baseline. So that's a very frequent thing. I'll ask patients or ask providers when they come up and they say, well, this patient's level is out of range. I don't know what's going on. And I'll say, okay, what was their creatinine clearance now? And they'll tell me. And I'll say, well, what's their baseline? And frequently they hadn't really thought about that. So you want to see not just what they are now, but what have they been previously as well. So looking at this, the appropriateness of digoxin therapeutic drug monitoring, is this a good drug to do that for? Do we have an adequate indication? Are we doing appropriate timing? And are we rationally interpreting the levels we're getting? That's one of the things we got to figure out. So in this case here, what would be a good reason to monitor for levels of digoxin? Well, it could be if we are suspecting toxicity or an adverse drug reaction. Maybe we have newly initiated treatment, right? So maybe this is a new drug for them. We want to make sure they're at the right range. Maybe they've had some instability in terms of clearance. We want to check on that. Or maybe they're just a high risk, right? Maybe they have high risk disease states that make them more susceptible to some of those pharmacodynamic differences. And I just want to go ahead and make sure they're at that good range to make sure they're not going to be at risk for toxicity. Other things could be drug interactions. Obviously, if you have a suspected overdose, good reason to check that out. Been some other change in kinetics you need to consider, and then also decision for future therapy. Sometimes you'll have patients who will just not get much effect out of a drug, and they'll be right there in the therapeutic range, and that may lead you to think, okay, well, I don't want to push the dose because that may lead to issues, so I'm just going to just go with another drug altogether potentially. So other things to consider too, like, is that drug at steady state, right? So depending on the half-life of the drug, you can figure that out now. So you can look at this half-life of a drug and how long the patient's been taking to determine, is it too early, too late? Those things you want to know. Sample timing, are they adherent to it? Looking at that spacing between the timing of the dose and the sample collection. I cannot tell you how many times I've had wrong levels being done in relation to the timing of a dose. Maybe you're trying to measure a peak level, but then they take the level before they give the dose, right? Or vice versa if you're trying to get a trough level. Those all can be issues. Blood sampling site is another big one too. I've had cases to where patients were basically, the nurse was infusing the drug into the patient, and then they took a blood sample out of that same line the drug was infusing through. So guess what happened? Well, the level's like sky high because of that. It was basically just pure drug they were measuring at that point with a little bit of blood in there. So there's that. Nicole asked, if this is a new patient who came in, how would you be able to compare to a baseline creatinine clearance? It's a really good question. Sometimes you can't. Sometimes you can call their previous providers and get some of those records. That can be possible. It's really nice if you have continuity of care there. So especially like with Nemours, for instance, all their stuff is interconnected. So if you go and see different providers within the Nemours network, you have all their records right there. But assuming that's not the case, you may have to call to their old providers and see what's available. Sometimes you just don't know, right? Sometimes you just have to go with, okay, this is the only data point that I have, so I don't know what their baseline really is. So it can be tough in a lot of cases. I do that a lot with my tox cases. They'll call me up and they'll say, okay, well, the EKG looks like this. I say, well, what's their baseline EKG? And they don't really know because they just don't have that information there. So it does provide a challenge in a lot of cases. But other things too is just, intra-patient variation. Some patients are just going to fall outside of that range in terms of where their efficacy and their toxicity are going to lie. So you got to be able to take that into account. So in terms of blood sampling logistics, as I mentioned, so potentially if a drug is given, the wrong dose is given or the wrong infusion rate, that can lead to abnormal levels too, right? So if if there's a mistake in the pharmacy and the pharmacy gave too much of the drug and the nurse didn't know about it, that could lead to a high level, right? Or maybe a dose was skipped, right? Why the dose might be skipped? Well, what if the patient had to go down to imaging to have a CT done and they couldn't get their dose at that time because it took a couple hours? Lots of reasons why doses may be missed in those cases there. You could have the dose given at the wrong time but the blood drawn at the right time, or vice versa. You could have the dose given at the correct time but the blood drawn at the wrong time. I've had every single one of these things happen, and you have to be able to call people, investigate, and kind of find out what's going on in order to make heads and tails of these levels here. So some factors also that can go with the drug sampling. I mentioned samples taken through the administration line can lead to really high levels. If the sample is taken from the wrong patient, as I mentioned with the twins example in the PEDS talk, we said that if you have patients in the same room, sometimes if you were to draw it from the wrong one, that could lead to issues. Sample handling issues can be a problem. So for instance, some drugs, when their levels are drawn, they have to be kept on ice. And if not, it can then change the level either high or low. So that can be an issue. And then I mentioned the wrong collection too, also can be a problem. In terms of the kinetics, sometimes patients fall outside the population average, and so you have to take that into account potentially. Was the drug drawn prior to steady state? That would lead you to have a level that looks too low. It may prompt you to try to bump up the level or bump up the dose when they don't really need that. And then, if the drug is drawn, blood is drawn at an inappropriate time based on the drug's kinetics. So, as we'll see here in just a moment, some drugs have what we call a distribution phase, where basically you give the drug, either IV or PO, and you'll find that it will sit there in the central circulation for a period of time, maybe a couple hours, and before it has time to really distribute out to the tissues. And so if you draw that level too early, you end up finding the level looks too high, whereas if you draw it a few hours later, it looks normal. So we'll see that's going to come up here in just a moment. Sometimes the wrong drug can be assayed. If they're on gentamicin, but you measured a tobramycin level, for instance, which can happen just due to computer entry errors. May have an endogenous substance that may cross-react with the drug you're looking for. That's rare, but can occur occasionally. And then issues in terms of like improper prolonged storage in the lab or just technical errors of the assay, right? You assume you send a thing off to the lab, they're going to give you the exact right answer back, but even they are can have errors that pop up. So in terms of case resolution here, we're going to see that digoxin actually ends up having a 6 to 8 hour distribution phase that occurs here. So what does that mean? Basically, if you draw that level too early, especially right after a dose is given, it appears to be falsely elevated. So here you investigate and find out the patient had actually taken the drug 2 hours prior to sampling, and so it's still in that distribution phase. When we took the level again at 6 hours after that, so 8 hours after the dose, it was 1.1 nanograms per ml. She was in range and no further intervention was needed, right? So again, your obvious thing would be the level's too high, let's stop the dose, let's cut it in half, whatever the case may be. But if you investigate it further, you may find you have to basically do nothing at all, right? It's kind of like hurry up and do nothing in some instances. So overall, this is a helpful tool, but again, you need to know how to use it. It's when you have a hammer, it's not that everything is a nail here. It needs to be very specific in how you're using it. Understanding those limitations, drawbacks, when it can be useful is very important. You'll learn more about that, and we'll get into it in Pharm 1 and 2 for specific examples. Okay, so any questions on that? So I don't see any new questions. So I do want to go over the prescription assignment, if that's okay with you guys, unless you just want to do it kind of blind. That's a possibility, but I'm going to assume you would like a little bit of help with that. Let me pull up the rubric here real quick. Okay, so here is the prescription writing rubric, and you're going to be using this for your assignment due next week, I believe on the 31st. So, and we're going to talk more about this in Unit 7, but I want to make sure you had time and we had some ability to go over this prior to the due date, basically. So there's two parts of this. There's a prescription writing rubric. This is the one for prescriptions that you would write that you would want the patient to fill out or get filled at like a CVS or Walgreens or something, right? So it's an outpatient prescription. There is also going to be a case for medication orders. This would be in the situation you're writing something in the hospital, right? So you can see here how this looks very different. This would be how you would write medication orders in the hospital as opposed to prescriptions. For this assignment, you're going to be doing this one here, the prescription writing rubric, okay? So basically, this is going to contain all of the information you need to fill out in order to appropriately fill a prescription for a patient. And you can see all the points here that you need to have in order to get full credit for the assignment, okay? All of this needs to be handwritten, okay? Most people will go ahead and write this down on paper, and they will take a photo of it and then submit that. Some people, and I do not have a problem with this, will go ahead and fill this out on a tablet using a stylus or something to write themselves. I don't care which one you do, but if it looks like it's font like this is not going to work, right? This is not handwritten. Thank you. I'd also like the scrubbed references. You need to make sure that you're not just like using a cursive script or a cursive font like that. It's not going to work. It needs to be actually handwritten. So whether it's digital or physical, I don't honestly care. Just make sure it's handwritten, and everything needs to be filled out by you. The point of doing that is one, slow and torturous punishment. Just kidding. Is mostly due to the fact that I think by doing this by hand, you at least get the kind of that physical memory, physical sensation of like all these different points you need to include to make sure that you have it there to make it a valid script. Because otherwise, people like me are going to have to call you back and get your clarification, and we get pretty cranky when we have to do that. So I don't want you to have to get calls from pharmacists. The less you have to interact with us, probably the better. You're going to get 2 years of me. That's all you need. That's a lifetime's worth. Let me tell you what. So anyways, what am I looking for? Basically here, you're going to be getting the name and address of the provider. You can make up whatever name you want. I don't really care. References are great. That makes it more entertaining for me. You would then fill in the patient name, date of birth, and address. You'll have the medication name and strength. It has to be something that's commercially available. So when you're looking up drugs, especially like in LexiComp, there's a whole section there called dosage forms, and that will tell you what is commercially available. If something comes as a 100 milligram and a 200 milligram capsule, and you write for a 150 milligram capsule, if that's not commercially available, want to count some points off. Let's see. Kelly says, I handwrote the drug assignment, but when going to turn in, only docx format was acceptable, and I couldn't submit a PDF. I apologize. I'm going to fix that right after that. Actually, I'm going to do it right now. It says file uploads, so it should be okay. I should be able to upload something. Should we use SIGs? You can use SIGs as long as they are correct. So if you're using the wrong SIGs, then that's going to be problematic. But anyway, so you're going to get the medication name and strength. So that'll be 1 point there. And then the big one is going to be instructions for use. I want you to have how much to use, how much to take, when and how often to take. You have to have the route there. Indication, which means if it's, say, for instance, here with metformin, we're using for glucose control. You can say for diabetes, whatever. And then PRN indication if applicable. So if it's something where you're taking like oxycodone, Q6 hours, PRN, you need to say PRN pain, right? Or PRN pain 7 out of 10, or whatever the case may be, right? Next, you want to have the dispense quantity, which should make sense based on your instructions for use. So if you say take something 1 tablet twice a day, continuous, and you're writing for a month's worth, then you should be writing for 60 tabs, right? So that needs to make sense there. Refills based on indication and dosing. So if it's something that's limited time, or if, say, you're using something for 7 days, then there's no refills. If it's a chronic med, you may want to put some refills. I want you to think about that and what's appropriate based on the indication. Then you want your date written and your signature with credentials, right? I don't care what the credentials are. If you made up some elaborate sort of persona for yourself, if he's an MD or a PA or whatever, just go ahead and put those credentials down there. PA S1 is totally appropriate too. So this is what you're going to do. You can use these blank boxes here. I encourage you to do that. It's going to be the easiest way to get those written out. Okay. So let's look at the assignment itself. Pull that up. So this one's going to be a little easier than what you'll see next semester because I'm trying to ease you into it gradually. And so here I've given you a lot of the information. So in some cases, I may not even give you what dose or what drugs to use. You may have to look up based on the indication, but that's going to be for a later time. Basically, we have 2 prescriptions you're doing this time, so we're going to use 2 of those boxes on there. And so the first one here, we have a patient with a gouty attack. We're going to do a 7-day course of meloxicam. So again, you already know the duration, but you got to look up what dose to use, right? So let's say I wanted to use a similar drug, but I want to show you what to look for here. So here in the case, we looked up the drug celecoxib or Celebrex. So Celebrex is another NSAID kind of in a similar class to meloxicam. And don't worry if you don't know what the drug is used for specifically, because we'll learn about that next semester. But I already told you what drug to use. But this is a similar one. And so when you're looking up the indication, you know, we're seeing, okay, this is an adult patient. They're 54 years old. And you may not see the exact dose or the exact indication here, but if not, look for something similar. So if gout wasn't here, then I could basically look for acute pain. That makes sense that I would use that interchangeably. But basically, I look here and I say, okay, well, it's 200 milligrams twice daily. I initiate within 24 to 40 hours of flare onset, preferably. Discontinue 2 to 3 days after resolution of clinical signs. Usual duration 5 to 7 days. If I were to say use Celebrex, if you wrote this entire thing out, that would be incorrect. A lot of this stuff is meant for providers' extra information. You don't need to, the patient doesn't need to know all that, right? Basically, what you would say is celecoxib, 200 milligrams PO twice daily, right? You already know they're having symptom onset, so they don't need to see initiate within 24 to 48 hours. So be cognizant. You don't want to just blanket copy and paste this entire thing because that's not really appropriate, right? So you're telling them how many days to take. So you'd say celecoxib, 200 milligrams PO twice daily for 7 days, right? And then you would see that if they're doing 200 milligrams twice daily for 7 days, the quantity is probably going to be 14, right? But let's look to see what our dosage forms are. So again, you can go down here, go to dosage forms. You can see here, Celebrex comes as either generic or a brand name, 50, 100, 200, 400, right? So if you wrote for 300 milligrams, doesn't really make a whole lot of sense, right? But 200 milligrams is available, so I could write for that as my strength on there. So say celecoxib 200 milligrams, and then you could write your instructions, right? So for the SIG for that, you could do 1T PO BID times 7 days, right? That would be totally fine there. If you need help with SIGs, let me know, but you should be able to find those resources online for sure. So there's that one. Again, I didn't give you the specific drug. I used something similar, so don't just use what I just showed you because that's going to be the wrong drug. Next up, I'm always going to put a pediatric prescription on here because I want you to get practice at doing these scripts for oral suspension. So that's why I included that here. You can see here he's a 21 kilogram male with strep. He's going to be getting amoxicillin suspension, 400 mg per 5 mLs. They're getting 50 mg per kilo once daily for 10 days. Okay. So for these, basically, you have to calculate how much they're going to get. You have to calculate the quantity they're going to receive. And again, for these, when you're doing the suspensions, just write down how much they're going to need to fulfill the script here. So if it's 320 mLs, just write 320 mLs. If it's 50 mLs, just write 50 mLs. Us on the pharmacy side, we'll figure out how much to dispense. Sometimes we'll just give a whole bottle for things that are short stability. Sometimes we'll give partial bottles. We'll figure that out. You just need to write down the amount that they actually need to receive for those sorts of things. Okay. I think that addresses most of the issues with those. Just want to make sure I took some time to actually go through that for you all and address any questions you might have. So any questions about that specifically? Okay, in regards to our drug assignment, I noticed some feedback from turning in software on plagiarism that flagged the questions themselves, not necessarily what we responded. Should we be concerned about that? I would not be concerned about that. Most people probably got the same thing. I'd use Turnitin. I take everything that Turnitin gives me with a huge rock of salt because I know it's going to flag a lot of stuff like that. So do not worry about your Turnitin score. If you know that you are not copying and pasting, I'll probably be able to tell that you weren't either. And so you should be okay to go from that standpoint. All right, so Marley's saying, just to be clear, we write a random RX and then we write an RX for each of the two cases you just showed us. No. You just want to use the two on the case that I showed you. So you're only going to do 2 prescriptions for this first one. In the future, there'll be 3 for each one. Sometimes I might even do more than that. But for this case here, you're just only going to be doing 2 prescriptions. If you want to write yourself a random third one, I guess you could, but I'm not going to grade it. So that would just be for your own fun, I suppose. Assuming you find that fun. Let's see what else. All right, Paige is asking, so we aren't doing the hospital one, correct? Yes, the hospital one will come later. I just include that all in the same rubric just to keep it in one document. We'll look at that later on, probably late fall semester. We'll start using that one, but just use the one for the actual prescription. So this first page here, I want you to work off of this one. This is the example. Again, hand fill in all this information. This is the stuff I'll grade you on. This is stuff I'll count points off for. And then just use these blank boxes. You can do that. Either scan in the picture, do it as a PDF, whatever the case may be. I double checked and it looked like it should be able to accept any document. So I'm not sure. Try uploading it again, and if it doesn't work, then just let me know. But otherwise, should be good to go. So that's it for me. I hope you all have a wonderful weekend. If you have any questions, feel free to let me know, and I'll be busy grading all of your drug information assignments. Okay, see, for the second RX case, you said to write the total number required or the dose or total to dispense. Yeah, so when you're doing that one, so for the amoxicillin one, basically you'd figure out how much, so you'd write the concentration that you're using, right, that 400 per 5, and then you'd write how many mLs to administer, and then the quantity is going to be the total amount to fulfill that that prescription. So if it's 10 mLs per day for 5 days, you just write 50 mLs down here. Okay. And that's David, if I think D. Correct. No problemo. You guys have a great weekend. Enjoy yourselves and stay safe out there. And I will see you whenever our next meeting is. Yeah, I wouldn't include any specific citations for the prescription assignment. You should be all right. All right, see you guys later.